Yeah, I did my presentation, my investigation on barriers for successful uptake and implementation of prevention of mother-to-child transmission of HIV services in one of the mission hospitals. Since we know that HIV is still rampant in all countries, not only my country, Malawi, but also in the whole of Africa. And why my specific interest in this subject was Malawi started in 2002 implementing this PMTCT. During that time, we were only using nevirapine. When the mother was in labor, would give nevirapine. And then after she has delivered, the baby would also get some syrup for about 7 days, and that was all. But with this practice, it showed that there was still a lot of transmission from mother to child, because if there's proper care to the mother during pregnancy, if she's HIV positive, there's a chance of reducing the transmission from the mother to the child by 30 to 45%. So in this regard, Malawi then changed the regime to option A, which consisted of 3 types of drugs. There was the zidovudine, lamivudine, and then we had the nevirapine again, but it was only also given to the mother at labor, with the continuation of the high transmission rate, because the transmission rate was supposed to come down with a change to option A, but it showed that transmission rate was still high, and there was transmission rate of 32%. All pregnant women who are HIV positive had an HIV positive child at the end of 24 months. So why I did this study is, after I did my literature review, despite that the government of Malawi introduced option B+, which was 3 combination of tenofovir, lamivudine, and efavirenz, women still who are HIV positive did not accept the treatment, despite that they knew that after they get the treatment they would have an HIV positive child. While some women who accepted the treatment ended up with an HIV negative child. So the question was, why such type of decision making among women despite being assured of the benefits of the treatment, and that the treatment was offered free. So I did this study among women who were HIV positive, those that were pregnant, those that were breastfeeding, and I also did a focus group study discussion with health workers that were working in the HIV testing counseling, those that were working in the prevention PMTCT clinic, and those that were working in the ARV clinic. I also did a focus group study discussion with pregnant women who were known to be HIV negative but had come for the clinic to attend antenatal. When I looked at when were these women tested for HIV, most of them were tested during antenatal. As in my country, it's a policy that all pregnant women, when they're attending antenatal, they have to go through testing and testing for HIV. So from this, I could tell that most of the women had not previously gone for testing, but only got tested when they were pregnant. In my discussion, I wanted to know what made these women stop during taking the ARVs. Then I discovered that the challenge was disclosure. Okay, most of them did not disclose the HIV result to their partner, despite that it's supposed to be after you get tested, you are supposed to share the results with the husband. So most of them did not share the results with their husband, but they kept them as a secret. So I also wanted to know, when would they wean their baby from the breast? Most of them said by 2 years they would have weaned the baby from breastfeeding. When I did the focus group discussion with the pregnant women who are not HIV positive, the age group was between 18 to 30 years. Most of that's the age range. The number of pregnancies, they were actually different from the other women who had HIV positive. Those ones were like 1 to 5, but these ones, majority of them was just 1 to 2 children. Most of them had not had a lot of children. Their level of education was still primary. Most of them had not gone far with their education. And so from the results, during the discussion, it was very clear that the women that when a woman tests HIV positive during pregnancy, she has several challenges which she encounters. Number one was disclosure result to sexual partner. It has been reported that there is violence when a woman reports that I'm HIV positive, the sexual partner, and it does not just end in the violence. You find that the woman is even divorced, so the husband would divorce her, or he would even be the first person to discriminate her because of the status. And another reason was the stigma and discrimination which was being there from the community. It's still rampant in our community that people still discriminate anybody who is HIV positive. And there was also another reason why women opt not to continue with the ARVs is because they heard that there's better treatment when you use the traditional medicine or you go for religious beliefs. And others were not sure what would be the outcome of their baby. So they thought that it's better they just stop the treatment all. During the focus group discussion with the women who had just come for antenatal, they were HIV negative, they understood that it is mandatory that you go for HIV counseling and testing during pregnancy. They knew about the option B+, which is long life treatment for positive women. And they also knew that the benefits of ARV is that they boost immunity and lower viral load so that the mother can remain healthy and does not pass the virus to the child. While the discussion with the health workers who worked in the HIV testing and counseling center, those that worked in PMTCT and the ARV clinic, the discussion showed that they encountered a lot of challenges due to limited number of health workers, so it led to overworkload and then burnout. They have a good linkage system between the HIV testing center and then the prevention of mother to child and then the ARV clinic. They do follow up all the defaulters because it showed that they have, on initiation it's good, but once the mother is around, she has delivered, the baby is 6 months, there was actually a 17% loss to follow up. And when the baby is now around 24 months, which is like 2 years, the defaulter rate went up to 23.5%. So, but in this kind of setting, they have a good follow-up system because they use expert mothers. They have who they call health surveillance assistants. And if the client has a phone, they are able to also follow up using the phone number. All programs related to HIV, they do an evaluation on all their programs once every quarter so that they can look at the challenges and also be able to implement new policies, which is there currently in my country. They've actually implemented a new HIV treatment guideline. They also do what they call outreach programs, because we know that sometimes the clients will tell us that I cannot come to the clinic because I live very far. So what they do is they have designated points close to residential areas in the villages. So my conclusion is, when I was doing this investigation, I made up a hypothesis that there was an association between barriers to prevention of HIV, mother to child, and the demographic variables such as age, education level, number of children, previous experience and knowledge. But it turned out to be there was no relationship, and this hypothesis was rejected. But one objective that I would have loved to have done is to actually also include the men whose wives were actually HIV positive, and how the system was, and how they were actually understanding PMTCT. So one of the objectives would have been to the experience of sexual partner after the disclosure of HIV results. Or how is it that when a man gets tested, how does he disclose the results to the wife? So currently, despite that, Malawi started this HIV prevention of mother to child in 2011 with a good number of women being enrolled. But over the years until now, we have seen that we are losing a lot of women along the way. We're having a lot to follow up. So my study was just trying to understand, why are women still not being there, or like, why are still these pregnant women, despite knowing that I'm HIV positive, I have to be on treatment for life? Why do they become lost to follow up? What is the reason? So most of the reasons that were stated were the ones that I've stated, that disclosure, and this disclosure is one of the big issues, because if the husband starts being violent to the wife, I don't think the wife, women can disclose the result. And stigma and discrimination, which is very wide in our community, because people still don't believe that you can associate with a person and not get it. They still feel that once you associate with such a person, you can still get the virus. Thank you very much.
Thank you for your presentation, Ms.Chisomo Deborah. That was a wonderful presentation. Dear participants, please raise a question and answer here. And in chat box, Deborah, please mention your email ID. Okay, now we go for the next session polling. Dear participants, please poll for Ms. Deborah on her presentation. Dear participants, please poll for Ms. Chisomo Deborah. The polling will be closed in 1 minute. So the polling is end here.